Hello everyone, this is Austin Kaiser back with you on part 2 of Introduction to Mechanical Ventilation, something called Feeling Obstructed. Our objectives over the next few minutes, we're going to review the patient population that we're talking about when we are looking at who is going to benefit from this strategy. We're going to understand the differences between protective and obstructed lung patients as well. So who are these patients? These are our COPD patients, but more specifically, they are our current exacerbation of emphysema, exacerbation of asthma patients who failed non-invasive and had to be intubated, or these are our patients for whatever reason is just not fully exhaling with the given I to E ratio that we were doing in a protective strategy, so we are going to need to switch them to this obstructed strategy. What is our goal with these patients? Our goal is very simple. It's to give them an adequate amount of time to fully exhale in order to not trap air in their lungs. When we're setting up our ventilator for our obstructed patient, it's very similar to the settings that we'd be choosing for our protective lung strategy with just a few little differences. So for our mode, we can still be using assist control. More advanced people may or may not use assist control versus SIMV for our obstructed patients, but much easier to talk about it in terms of assist control when we're first learning. Our tidal volume, we're going to start off at 8 milliliters per kilogram of their ideal body weight. We're going to start here and we can work down if we need to. Our I time still is a comfort dial. However, it would seem very obvious to us that the less time you spend inhaling equals the more time you spend exhaling. So by shortening the I time and spending less time to get a full breath, our patients are going to be spending more time exhaling. Really what we are doing when we are changing the I time, or when we're looking at the I time in the obstructed patient, is we are really keeping in mind the I to E ratio. The I to E ratio is incredibly important with these obstructed patients, and it helps us to understand what this means. So what is the I to E ratio? It is the amount of time inhaling, or amount of time during inspiration, compared to the amount of time exhaling. So if we have an I time of 1 second, and we are breathing 20 times per minute, we have a respiratory rate of 20. That means that we spend 20 seconds of every minute inhaling, which means that we have 40 seconds of every minute spent exhaling. So that person would have an I to E ratio of 1 to 2. In the protective lung strategy, an I to E ratio of 1 to 2 or 1 to 3 is absolutely appropriate, and the patient oftentimes is not going to have any issues whatsoever with that. But in the obstructed lung patient, a 1 to 2 or 1 to 3 is not going to be adequate for them. It will not allow enough time for them to exhale. So we are going to need to draw that out as much as possible with having a minimum I to E ratio of 1 to 4. But if we can get 1 to 5, 1 to 6, or 1 to 7, then that would be absolutely ideal. PEEP and FiO2 is very different with the obstructed lung patient than it is with the protective, as we do not follow the ARDSNet strategy for mechanical ventilation at all. We will set the FiO2 to maintain whatever saturations we need. However, we will not be using the normal PEEP scale. As far as PEEP goes, with our PEEP and FiO2, we will set our initial PEEP setting anywhere from 2 to 5 centimeters of water pressure. We may need to go up between 5 and 8 if we are having issues with low compliance or issues with low saturation, even though we have an FiO2 of 100%. But we really would like to keep our PEEP lower because we do not want to be contributing to the amount of AutoPEEP that the patient is having. It can be very difficult for them to exhale fully if they have 8 of PEEP in their alveoli. We can see on this graph to the right that that expiratory curve is the patient is breathing out, breathing out, breathing out, but that yellow line never quite gets back to the baseline before they start inhaling again, means that there was some amount of volume left inside of the lungs after that patient was done exhaling and was never able to fully exhale. That is going to continue to stack and stack inside of the lungs, and this patient will potentially eventually have a large problem. Respiratory rate is probably the most important dial in this obstructed lung patient, as this is what really is going to give them the biggest bang for their buck when it comes to the I to E ratio. We are going to start with respiratory rates of 10 to 12, so we are already down at a very low range of respiratory rate. And this is going to cause some pretty marked hypercapnia in many of our patients. However, this permissive hypercapnia is tolerable to these patients, as most of them live with a fairly high PaCO2. They may need some additional pain control and sedation because it is uncomfortable to be hypercapnic. Like I said in part 1 of this series, sometimes patients will feel like they're drowning, so they can be very difficult to sedate. However, if it comes between a need for additional sedation and your patient auto-peeping and trapping a lot of air in their lungs, we're going to go ahead and take the sedation every time. We do not want these patients spontaneously breathing because that's just going to contribute to air trapping in their lungs or auto-peeping in their lungs. So we really need to make sure that these patients are well sedated, that they have a lot of pain control on board, that if they are spontaneously breathing, we may or may not think that it's prudent at the time to reparalyze them, so that way they are not taking any additional spontaneous breaths, whatever we can do. So the whole reason that we do this strategy is to prevent something called auto-peeping in the lungs. And what it is it's the stacking of air in the lungs that would be absent if the patient were allowed to fully exhale. What we really want to avoid is walking into that room and seeing that barrel-chested person as they have 25 milliliters per kilogram of air trapped in their lungs, and they can't get rid of it, and their vital signs are tanking, and they are in a peri-arrest because we did not allow them enough time to exhale. There are many ways to check for AutoPEEP on our ventilators and on our cardiac monitor. In this specific example on this photo right here, you can see that flow waveform as the patient is attempting to exhale and they never quite get back to baseline before the next breath, which means that there was some amount of air that was left inside the lungs between breaths. These two photos show much the same thing. On the right side, more specifically, one benefit that you might be able to use your cardiac monitor with is that when you have your patient on end-tidal CO2, you'll notice that you have 3 numbers come up. You have your end-tidal CO2, your respiratory rate, and your FiCO2, which is the fraction of inspired carbon dioxide, and that number should be 0. If it's more than 2, you have an auto-peeping issue. So how do we check for AutoPEEP in our patients? We are going to perform an expiratory hold or an E hold. We learned on part one how to perform an eye hold in order to determine what our plateau pressures were, and the same button is used to perform an E hold on the Ravel, or an expiratory hold. If the AutoPEEP is less than 4, then the patient is safe. If the AutoPEEP is greater than 4, the patient is trapping to the point where it is going to eventually become a problem for you. So the first thing that we can do if our patient is auto-peeping is go down on our respiratory rate. If we were at a rate of 12 breaths per minute, we can go down to 11 or 10. You do get a lot of bang for your buck when you're talking about increasing or decreasing your respiratory rate, so you don't need to drop it precipitously. You can drop it just 1 or 2 breaths per minute, and that will give you a lot more time to exhale. If we are bottomed out on our respiratory rate, say we have an adult and the respiratory rate is already set at 10, our next step would be to decrease our tidal volume. It's much easier to breathe out 7 milliliters per kilogram than it is to breathe out 8 milliliters per kilogram. If you have a bottomed out respiratory rate and you have a very small tidal volume and you believe that your patient wouldn't tolerate any additional hypercapnia from reducing either one of those two numbers in step 1 or step 2, step 3 would be to shorten the eye time. So if you have an eye time of 1 second and you reduce it down to 0.8, you're going to give your patient a little bit more time to exhale. In review, our obstructed strategy is as follows. Our mode is assist control. Our starting tidal volume is 8 milliliters per kilogram of our ideal body weight. You may be able to, or you may need to reduce that if we are auto-peeping. Our inspiratory flow rate, or our eye time, is set to 1 second. Our FiO2 and PEEP, we're going to be doing lower PEEPs, somewhere between 2 to 5 centimeters of water pressure starting out. And we are going to be using higher FiO2s in order to maintain good oxygen saturation. Do not use the ARDSNet scale, as this would contribute to further auto-PEEP in our patient and be very dangerous for them. Our respiratory rate is the big setting in this strategy. We're going to be using lower respiratory rates, anywhere from 10 to 12 breaths per minute starting. Make sure that we are continuously checking the expiratory hold in this obstructed patient and do not let them auto-PEEP. Do not let them have an auto-PEEP greater than 4. And we are going to allow for permissive hypercapnia. Anything above an end-tidal CO2 of 50 is going to be very uncomfortable for our patients, and so they may need additional sedation. We're going to be using our primary adjunct of ketamine or propofol for sedation, and don't forget to add fentanyl on top of it to help with any discomfort from that hypercapnia and from the positive pressure. So case number 4, we have a very obstructed 25-year-old male who arrived at the ED with asthma exacerbation after smoking methamphetamine. EMS did some albuterol and Atrovent through a handheld nebulizer during the pre-hospital care. They did some intramuscular epinephrine and CPAP. In the emergency department, they originally tried non-invasive with BiPAP and some inline nebulization. However, he was dog pant breathing and tired, so the decision was made to intubate. The patient was placed on the ventilator with assist control volume as the mode, has a tidal volume of 500 milliliters, a respiratory rate of 14, an eye time of 1 second, a PEEP of 5, and an FiO2 of 50%. He has an ideal body weight of 65 kilos. So we run back into the room because of several alarms going off. We see that our vital signs are as follows. He has a blood pressure of 62/40, a heart rate of 155, and a pulse ox reading 71%. The vent has multiple alarms going off on it right now. So imagine yourself in this room and there really should only be one thing on your mind. What is your number one priority for this patient? All right, case number 5. We have a 51-year-old female who was intubated after failing non-invasive for exacerbation of her COPD. She's 5'6" with an ideal body weight of 60 kilograms. What are our initial ventilator settings going to be for this patient? Great, so you have successfully placed her on a ventilator, and after 15 minutes or so at those settings, you notice that her peak inspiratory pressures are climbing, and you decide to perform an additional E-hold, and you see that her AutoPEEP is registering at 9 centimeters water pressure. What are your next actions? All right, thanks guys for hanging out with me again on part 2 of Introduction to Mechanical Ventilation. Again, my name is Austin Kaiser, and if you have any questions or comments about this presentation, please feel free to reach out to me at akaiser@phiaeromedical.com.